Good afternoon, everyone. My name is Swathi, and today I'm going to present on imaging in ischemic stroke. So the goals of today's presentation are to understand how imaging studies help in stroke diagnosis through examining findings in patients at different stages of ischemic stroke, and to know the advantages of different imaging modalities in ischemic stroke imaging. So what is stroke? Stroke is a common term meaning a neurological condition due to vascular lesions of the brain caused by hemorrhage, embolism, thrombosis, or ruptured aneurysm. The following are the most common etiologies of stroke, the most common being the cerebral infarction, the other causes being primary intracranial hemorrhage, non-traumatic subarachnoid hemorrhage, venous occlusion. But in today's presentation, my main focus is on cerebral infarction. So brief background on cerebral edema. The following are the various types of cerebral edema, and they are cytotoxic edema, vasogenic edema, interstitial cerebral edema, and osmotic types. And I'll be discussing in detail regarding the cytotoxic and the vasogenic types of cerebral edema. Coming to the cytotoxic edema, in this, the blood-brain barrier remains intact. It mainly occurs due to disruption in cellular metabolism that impairs functioning of the sodium and potassium pumps in the glial cell membrane. And this impaired functioning of the pumps leads to cellular retention of sodium and water. But in ischemic stroke, the lack of oxygen and glucose leads to breakdown of these pumps, leading to massive buildup of the ions in the brain cells, which causes a rapid uptake of water and subsequent swelling of the cells. So this is a picture showing a neuron. This is the glial cell membrane with sodium potassium pumps. This is how a normal cell looks like. Whereas in ischemic stroke, what happens is that the sodium potassium pump gets destroyed, and there will be increased ionic concentration of sodium and calcium, because of which the water enters the intracellular space and it causes swelling of the cells. The following are the causes of cytotoxic edema, and they are early ischemia, encephalopathy, early hypoxia, severe hypothermia, and various toxins such as dinitrophenol and hexachlorophene. So this is again a picture showing cytotoxic edema in which there is cellular swelling because of the damage to the sodium potassium pumps, and there is influx of water into the cells. These are the normal cells, and these are the cells that underwent cellular edema. And now coming to the second type of cerebral edema, which is vasogenic type. Vasogenic edema occurs due to breakdown of the tight endothelial junctions which make up the blood-brain barrier. The interendothelial fenestration gets widened, which allows the intravascular proteins and fluid to penetrate into the extracellular space. Once the plasma constituents cross the blood-brain barrier, the edema spreads. And this type of edema is quite rapid and extensive. So in vasogenic edema, what happens is that the endothelial junctions become leaky, the fenestrations get widened, because of which the water and the proteins get escaped into the extracellular space. Here, the cellular architecture is maintained, but there is fluid accumulation in the extracellular space. Coming to the causes of vasogenic edema, and they include trauma, various brain tumors, focal inflammation, late stages of cerebral ischemia, and hypertensive encephalopathy. A brief background regarding the arterial territory so that we can understand the imaging in stroke in a better way. So these are the parts in red are the ACA territory, ACA meaning the anterior cerebral artery territory. The anterior cerebral artery supplies the medialmost portions of the frontal lobes, and the branches of the ACA also supply the medial parts of the basal ganglia, and also the anterior 2/3 of the cerebral cortex. The parts in yellow are supplied by the MCA, that is the middle cerebral artery, and the lenticulostriate branches are also they are also the branches of the middle cerebral artery, and they supply the lateral portions of the basal ganglia. And the parts in green are supplied by the posterior cerebral artery, which supplies the posterior thalami as well as the occipital lobes. And parts of midbrain are also supplied by the posterior cerebral artery. And the cerebellum is supplied by the superior cerebellar artery, and the inferior portions are supplied by the anterior inferior cerebellar artery and also the posterior inferior cerebellar artery. And in this slide, this is the picture showing the vascular territory of the ACA. And these are the axial CT images showing INFARCT, which is characterized by hypodensity in the right ACA territory. And this is the picture of the MCA. This is the vascular territory of the middle cerebral artery in the brain. And these are the axial MRI images showing INFARCT in the MCA territory. This is an angiogram image showing a flow it is showing a flow defect in the branches of the MCA. And this is the PCA vascular territory. And these are the axial images showing INFARCT in the left PCA territory. And these are the axial and coronal MRI images showing INFARCT in the superior cerebellar artery territory. And these are the coronal MRI images of the brain showing the INFARCT in the left posterior inferior cerebellar artery territory. Now coming to ischemic stroke, it results because of significantly diminished blood supply to all parts or selected areas of the brain. The symptoms and clinical behavior is determined by the vascular territory that is affected. So the most common etiology of ischemic stroke is large vessel occlusions. Large vessels meaning they can be anterior cerebral, middle, and posterior cerebral arteries. The other etiologies include small vessels occlusions causing lacunar infarcts. Cardiac emboli can also cause infarcts, and watershed infarcts caused by hypoxic ischemic encephalopathy. And non-etheromatous occlusions due to vasculitis and vasculopathy can also cause ischemic stroke. All these that are shown in the slide are some of the stroke mimics. These are the important differentials, and these need to be identified. So hemorrhage is one of the stroke mimics. Brain tumors such as gliomas, meningiomas, and primary CNS lymphomas also mimic stroke. Demyelinating disorders such as multiple sclerosis and migraine can also mimic stroke. So what is the role of imaging in stroke? So imaging plays a very important role in ruling out the mimics, especially the hemorrhage. And they also suggest the therapeutic role, and they can also establish the etiology of the stroke. The following are the various radiological tests that are employed in identifying the stroke etiologies. And they include CT with or without IV contrast, CT angiogram studies, CT perfusion imaging, MRI with or without contrast, conventional MRI studies showing T1, T2 flare and gyri sequences, diffusion and perfusion MR studies, and MR angio and MR perfusion imaging. So perfusion imaging or functional studies, they can identify stroke at a very early stage when there is reduced blood flow. And diffusion MR imaging can also study early stages of stroke when there is cytotoxic edema. Whereas conventional MRI and CT images can detect abnormalities like in later stages of stroke. So perfusion imaging can identify stroke at very early stage. Now coming to the CT imaging of cerebral infarcts. CT helps in distinguishing between hemorrhagic and ischemic strokes. The imaging manifestations of cerebral ischemia, they vary significantly with time. And it is divided into hyperacute stage, which is less than 12 hours after onset of symptoms, acute stage, which is between 12 to 48 hours within onset of symptoms, and subacute stage, which is 48 hours to weeks, and chronic stages, that is weeks to months after the onset of stroke symptoms. So coming to the hyperacute stage, which is less than 12 hours after the onset of stroke symptoms. The CT brain in this stage can be normal in up to 50 to 60% of patients. And some of the CT abnormalities that can be detected are the hyperdense artery uh, sign can be seen, which is dense MCA sign. It is due to acute intraluminal thrombus. And the other subtle signs include obscuration of the lentiform nucleus. So this is an axial non-contrast CT image showing the dense MCA sign. This is the right middle cerebral artery with an intraluminal thrombus, because of which it is appearing hyperdense on plain CT. And this is a hyperdense dot sign in which one of the branches of MCA is occluded from the thrombus, and one of the branches in the sylvian fissures appears hyperdense. This is called hyperdense dot sign. The corresponding angiogram image also shows a filling defect here, indicative of a thrombus. This is an axial CT image showing hyperdense basilar artery. This is the basilar artery. The normal basilar arteries are not hyperdense, whereas in stroke, because of the intraluminal thrombus, the hyperdensity is because of the thrombus. And the corresponding angio image showing flow defect in the basilar artery. The other subtle finding is obscuration of the lentiform nucleus. So this is an axial CT image. This is the caudate nucleus. This is the putamen. On the right side, which is normal, we are able to appreciate them in a better way. Whereas in acute stroke, this definition is lost. There is a subtle hypodensity. So this feature may be seen on CT images within 2 hours after the onset of stroke. Now coming to acute stage, which lasts between 12 to 48 hours. In this also we see the basal ganglia to be hypodense, and there is loss of gray-white interfaces, which is also called insular ribbon sign. And there is also sulcal effacement. So what is insular ribbon sign? Insular ribbon sign is the hypodensity and swelling of the insular cortex. Insular cortex is the cortex that is adjacent to the sylvian fissure. The normal insular cortex is hyperdense, but in stroke, the density decreases and it appears hypodense. So it is a subtle early CT sign of infarction. These are again axial CT images showing focal parenchymal hypodensities with mild mass effect and obscuration of the lentiform nucleus, which is consistent with early CT changes of middle cerebral artery stroke. This is also an axial CT image showing hypodensity and loss of gray-white matter differentiation of the right insula, the lenticular nucleus, and also part of the internal capsule. This is the normal site in which the insular cortex can be seen hyperdense, and this is the infarcted side. Now coming to the subacute stage, which lasts from 48 hours to 2 weeks. It is divided into early subacute stage and late subacute stage. In early subacute stage, which is the first 1 to 3 days, there is an increase in mass effect. The CT abnormalities include wedge-shaped low-density area that involves both gray and white matter. Hemorrhagic transformation can also occur particularly in basal ganglia and cortex. And in the late subacute stages, there is gyral enhancement with persistence of mass effect and edema. This is a non-contrast CT axial image showing subacute infarct on the left side, which is appearing hypodense and is also showing mass effect. We can see that the lateral ventricle here is compressed because of mass effect. And in the late subacute stages, there is gyral enhancement. We can see the gyral enhancement here on the left side of the CT image. And in this slide, let's talk about the evolution of infarct from 1 to 8 weeks. During this stage, the infarct shows contrast enhancement. It still persists in this time frame also, and the mass effect resolves. The swelling also starts to subside, and small amounts of cortical petechial hemorrhages result in elevation of the attenuation of cortex. This is known as the CT fogging phenomenon. So imaging of a stroke at this point can be very misleading, as the affected cortex will appear near normal. So these are the axial CT images on the second day and ninth day of a post-stroke patient. On the second day, we can see the hypodensity clearly, whereas on the ninth day, because of the CT fogging effect, the hypodensity is not appreciated, and this becomes misleading. And these are all the axial CT images showing the evolution of the infarct. So this is the brain CT image in acute phase ischemic stroke in the right MCA territory. We can see that the findings are very subtle. Whereas this is the image that is taken at 36 hours after hospital admission, and it clearly shows the infarct as hypodense region in the right MCA territory. And the third image here is the CT image that is taken after 2 weeks. We can and in this image we are not able to clearly appreciate the infarct. This is the subacute stage of the infarct, which can be very misleading. And this is the contrast enhanced axial CT image showing contrast enhancement. The infarct is showing contrast enhancement. Now coming to the chronic stage. In chronic stage, we see encephalomyelitic changes and volume loss causing atrophy of the brain of the infarcted site. Calcification can also be seen, but is rare. So these are the appearances of chronic infarcts. This is in the right occipital region, and this is in the central sulcal region. Now coming to the role of contrast enhanced CT. CECT has no role in acute stroke, but it helps in delineating infarct in the subacute period. Coming to the limitations of CT, 60% of the CT are normal in the first few hours. It is very difficult to detect early subtle changes, and hence MRI proves to be beneficial. Coming to lacunar infarcts are small, deep cerebral infarcts. They are about 3 to 15 mm in diameter, and they are typically located in the basal ganglia and thalamus. Small infarcts are, and these infarcts are small and they're often multiple in number, and there are not many lacunar infarcts are seen on CT. This is an axial CT image showing a lacunar infarct in the left thalamus. Now coming to watershed infarcts, the most common cause is hypoxic ischemic encephalopathy. It is the consequence of global perfusion or oxygenation disturbance in the brain. And the most common causes of HIE are severe prolonged hypotension, cardiac arrest with successful resuscitation, profound neonatal asphyxia, and carbon monoxide inhalation. Two basic radiologic patterns can be identified in HIE, and they are border zone infarcts and generalized cortical necrosis. So this is an axial CT image showing a border zone infarct between the ACA and the MCA distribution. The most frequently and severely affected area is the perito-occipital region at the confluence between the ACA, MCA, and PCA territories. The basal ganglia are also some of the common sites that are involved in HIE. And the most commonly observed finding on NECT is a low density band at the interface. So this is an axial CT image showing a hypodense area on the right side at the interfaces at the junction of the ACA, MCA, and the PCA territories. Now coming to CT angiography. CT angiography typically involves a volumetric helical or spiral acquisition that extends from the aortic arch to the circle of Willis. The examination is performed using a time-optimized bolus of contrast material for vessel enhancement. And the CT angiography, it helps in demonstration of significant thrombus burden that can guide in therapy in the form of intra-arterial or mechanical thrombolysis. This is an axial CT angiographic image showing left MCA obstruction here. This is also an axial CT angiographic image showing left MCA obstruction. There is no contrast fill in the MCA and its branches. And the corresponding CT axial image is showing a dense MCA sign. Now coming to the advantages of CTA, it is non-invasive and easy to interpret, and it can detect the plaque morphology very well. And images can be acquired very quickly and is widely available and can be done even in emergency setting. It is cost effective and it is not affected by complex flow dynamics such as MR, angio, and Doppler. And it also has ability to distinguish vessel occlusion from near total stenosis. Coming to CT perfusion imaging. CT perfusion imaging, it provides information about the brain perfusion. It permits differentiation of infarcted tissue from penumbra. And it's also analyzed with CT perfusion analysis software to create color-coded maps of cerebral blood volume, cerebral blood flow, and the mean transit times. These are the parameters that are assessed in CT perfusion imaging. Cerebral blood volume is the volume of blood per unit of brain tissue. Cerebral blood flow is the volume of blood flow per unit of brain tissue per minute. And MTT is the mean transit time. It is the time difference between the arterial inflow and the venous outflow. Time to peak enhancement is the time from the beginning of contrast injection to maximum contrast concentration. So the basic concept with CT perfusion imaging is that with MR diffusion and CT images, we can get a good impression of the area that is infarcted, but we cannot preclude a large ischemic penumbra or the tissue that is at risk and can potentially be saved with treatment. With perfusion studies, we monitor the first pass of an iodinated contrast bolus through the cerebral vasculature. Areas of decreased perfusion will tell us which area is at risk. These are the CT perfusion maps of MTT, that is mean transit time, of cerebral blood flow and cerebral blood volume. So here we can see the infarcted core on CBV and the infarcted core with ischemic penumbra on CBF. So these are again CT perfusion maps of cerebral blood volume and cerebral blood flow. So in the left cerebral hemisphere, we can see a region of decreased blood volume, which is seen in the white oval, that corresponds to the ischemic core, and a larger region of decreased blood flow. This is the larger region of decreased blood flow that includes both the ischemic core and a peripheral region of salvageable tissue. The difference between the two maps, that is the difference between the black oval and the white oval, gives the ischemic penumbra. So the interpretation of PCT can be done using these parameters, that is MTT, CBF, and CBV. We can see that in arterial stenosis and in oligemia, the CBF and CBV can be normal to near normal, whereas in the penumbra and the infarct, the CBF and CBV are markedly reduced. The mean transit time is increased in arterial stenosis, oligemia, and penumbra, but it is more so in cases of infarct. Coming to the MRI imaging for acute stroke. So the MRI imaging modalities that are used are conventional MRI images, which includes T1, T2, flare, and gradient sequences, and MRI diffusion studies, MR angiography, and MR perfusion studies. So conventional MRI images are more sensitive and specific than CT in acute stroke. The sequences employed are these: T1, T2 flare, and gradient echo. The following are the spectrum of MRI findings in stroke. So immediately, that is in hyperacute stage, the MRI findings can be merely absence of normal flow void. This can be detected within minutes of the symptoms. In less than 12 hours, anatomic alterations on T1 can be detected. Some other findings include sulcal effacement, gyral edema, loss of gray-white interfaces. And in the acute stage of stroke, that is between 12 to 24 hours, hyperintensities can be detected on T2 weighted images, along with mass effect and meningeal enhancement can also be seen adjacent to the infarct. In the subacute stage, that is in the early subacute period, between 1 to 3 days, there is early parenchymal contrast enhancement. Hemorrhagic transformation can also occur during this phase, which can be detected on MRI. Like in the late subacute stages, there is striking parenchymal contrast enhancement. Edema starts decreasing, and in 1 to 8 weeks, the infarct shows contrast enhancement. I mean, it persists. The contrast enhancement persists throughout the 1 to 8 weeks. The mass effect starts resolving, and there is also a decrease in abnormal signal on T2 because of fogging effect. And months to years after during the chronic stages of the infarct, encephalomalacic changes can be appreciated on the MRI. So these are the axial T2 weighted MR. This is the axial T2 weighted MR image showing hyperintense vessel sign. The normal vessels will show a flow void here on the right side, whereas in acute stroke, the T2 weighted images show lack of that flow void. And this is the corresponding FLAIR MR image showing punctiform hyperintense vessels in the left sylvian fissure, suggesting slow flow or thrombus in insular branches of middle cerebral artery. So this is the hyperintense vessel sign. The other changes, MRI abnormalities that can be detected are hyperintense and swollen cortical gyri. This is a FLAIR axial MR image showing hyperintense and swollen cortical gyri in the frontal lobes. A corresponding diffusion weighted MR image shows diffusion restriction in this area, but not in the frontal lobe. So this suggests that this infarct is not an acute infarct, whereas the one that has underwent diffusion restriction appearing hyperintense on DWI is an acute infarct. So coming to diffusion weighted MRI, diffusion MRI is uniquely sensitive to detect earliest changes within 90 minutes. The sensitivity and specificity of the diffusion MRI is very high, and it is between 86 to 100%. Acute infarcts on diffusion weighted imaging appear bright and they have low ADC values, whereas chronic infarcts, they appear hypointense on diffusion and they appear hyperintense on ADC. So diffusion weighted imaging, it makes use of the movement of the water molecules within the tissues. The normal motion of water molecules within the living tissues is random. Acute stroke causes excess intracellular water accumulation. Like I said, it's because of cytotoxic edema, with an overall decreased rate of water molecular diffusion within the affected tissue. So these areas appear bright compared to normal tissues on diffusion weighted imaging. So this is a DWI image showing diffusion restriction areas appearing hyperintense in a patient with acute stroke-induced cytotoxic edema in the right cerebellar hemisphere. Changes in diffusion weighted imaging occur within 30 minutes of the onset of ischemia, with corresponding reduction in ADC values, and it is seen up to 5 days. And DWI alone cannot be used and should always be compared to ADC to assess the age of the infarct. So these are the axial diffusion weighted and ADC maps of a 77-year-old man who presented with acute stroke. So on the diffusion weighted images, we can see there is hyperintensity in bilateral thalami and also in the occipital lobes. And the corresponding ADC images show hypointensity. So these findings are indicative of acute ischemia. Whereas in chronic infarcts, the diffusion weighted images show a hypointensity and the corresponding ADC maps show hyperintensity. So these findings are suggestive of chronic infarction. In this slide, we can see that the evolution of infarcts and their appearances on MRI with time. So in the acute phase of the infarct, on T2 weighted MR images, there are no findings, or the findings are very subtle. But with time, the signal intensity of the infarct increases on T2 weighted images, whereas on DWI, that is diffusion weighted imaging, the acute stage of the infarct appears bright on DWI, and the brightness comes to a peak at around 7th day, and then the signal intensity starts dropping down. Whereas in ADC maps, the signal intensity initially is less, that is, it is hypointense in acute stages, and with time, the signal intensity increases and the chronic infarcts appear bright on ADC sequences. So coming to MR angiography, MR angiography is very sensitive for detecting intravascular thrombus. The two pictures that are displayed here are MR angiograms in two patients with acute stroke symptoms. And these reveal flow gaps in the left proximal middle cerebral artery and also flow gaps in the basilar artery. Coming to perfusion MRI. Perfusion MRI allows measurement of capillary perfusion of the brain. It uses an MRI contrast agent called gadolinium. It can identify areas of hypoperfusion, that is the reversible ischemic areas as well, which diffusion weighted images cannot identify. So the lesion which shows changes in both diffusion and perfusion MR is the infarct core, and the lesion which shows changes only in perfusion MR is the penumbra. Diffusion weighted imaging depicts irreversibly damaged infarct, whereas perfusion weighted imaging reflects the complete area of hypoperfusion. The volume difference between these two, that is the perfusion and the diffusion mismatch, would be the penumbra. So in this slide, this is the diffusion weighted MR image showing an area of mildly increased signal intensity in the right parietal lobe. The ADC values in this region were decreased. This means that it is an acute infarct. And this is the perfusion weighted MR image showing a larger area of hypoperfusion. So the mismatch between the perfusion and the diffusion images is indicative of a large penumbra in this case. So the diffusion and perfusion MR images can be combined, and the mismatch can detect the penumbra, that is the tissue at risk, which can potentially be saved with management. Coming to some miscellaneous techniques that are also employed in detection of stroke etiology, they include transcranial Doppler ultrasound and MR spectroscopy. Transcranial Doppler ultrasound is primarily used for monitoring of post-subarachnoid hemorrhage and post-traumatic vasospasm. It can also be used in acute MCA occlusion. The findings include unobtainable MCA flow signal or significantly depressed MCA flow velocity. So there are two approaches in transcranial ultrasound. That is the temporal approach, in which you can see the anterior, middle, and posterior cerebral arteries, and the suboccipital approach, in which you can see the vertebral and basilar arteries. So this is how a transcranial Doppler ultrasound image looks like, in which we can see the anterior, middle, and posterior cerebral arteries. Coming to the MR spectroscopy, it can be used to observe ischemia-induced changes in cerebral metabolism. It is characterized by decreased N-acetyl aspartate, creatinine and phosphocreatinine, and elevated lactate. Yeah, thank you.